So we're on the nodal system, which is also the pacemaker system of the heart, and it's the intrinsic conduction system. And we have specialized cells, specialized heart muscle cells that act like, kind of like they're neurons. They're not neurons, but they are neurons. They are the neurons of the heart muscle itself that keep it automatically beating. In those zombie movies and vampire movies and stuff like that, one of the things that if they want to enhance the reality of the viewer's experience, when they reach into somebody's thorax and they pull out their heart, it should still be beating in their hand, because the heart was born to beat. And so it has its own electrical system that tells it to beat, and that's why our notes here say action potentials generated by non-contractile cardiac cells. So these cells are going to act more like neurons than they are going to act like typical heart muscle cells. What's interesting about these conduction system cells is that they have an unstable resting membrane potential. You remember resting membrane potentials were around minus 70 millivolts? So I want you to continue with that trend. Now, I want you to realize that was what we did with neurophysiology. The only thing that differs with some of our myo type of physiology is that maybe it might be minus 80 millivolts. That part's not important. I want you guys to stick with the minus 70 millivolts, because as you go throughout your careers, you'll probably never hear about the millivolts for a resting membrane potential. But realize that all the numbers are going to be very similar. They're going to be a negative number. So minus 70 millivolts is what we were used to. And then when we had an action potential, remember, it's only 100 millivolts change for an action potential. Same thing. We're going to stick with that. So that 100 millivolt action potential takes us up to a positive 30 millivolts. And then we all know that that rise was due to sodium. And then when we hit that 30 millivolts, that caused the sodium gates to close in an action potential and caused our potassium gates to open. That philosophy will be carried over, but here in our heart muscle cells, we have a little bit different player here. We already talked about what happens when a heart muscle cell has an action potential. Now we're on kind of the nervous system of the heart itself. And remember, calcium is suddenly coming into play with our heart muscle cells and cause that plateau phase that we saw earlier with a more blocky instead of a spiky looking action potential. So we have these resting membrane potentials that are unstable and will create what is called a pacemaker potential. And that is because what causes their lack of stability is that they're extra leaky to sodium. And sodium is going to move in which direction across the membrane of a cell? Into the cell. So sodium is going to go into the cell, and it's going to do what to the overall inside charge of the cell? Make it more positive or less negative, either way, okay? And we remember threshold. Do you guys remember threshold was that minimal amount of voltage change that the cell needed to experience to actually generate an action potential, correct? Same thing here. We have threshold for heart muscle cells. So we have sodium leaking into these pacer cells or these nodal cells, and while sodium is leaking in, we have to pay attention to what potassium is doing. Well, potassium is not leaking out anywhere near the rate that sodium is leaking in. So these cells are very leaky to sodium and not leaky at all to potassium, because if they were leaky to both, we'd end up with basically keeping our resting membrane potential at around minus 70 millivolts, which is what we're used to. But because potassium doesn't leak out and sodium is leaking in, this brings us to our threshold. And once we reach threshold, we get an action potential in these nodal cells, just like we got an action potential in a neuron. Okay? So we'll get an action potential in these nodal cells. This action potential, however, is quite a bit different from what you're used to. You guys are used to sodium causing the upward spike on the action potential, yes? Well, sodium is playing a minor role in the upward spike. So sodium entry, minor role in depolarization. That's our upward spike. With these nodal cells, when we reach threshold, calcium is the one that's responsible for the majority of that upward spike. And it's calcium entry is the major ion in our depolarization of our nodal cells. Once we hit our, let's go ahead and stick with positive 30 millivolts, we have any sodium gates that were open closed. And remember, that's a minor role. And we have now calcium gates closing, but they close slowly, and we have potassium gates opening. So still all what we learned about with potassium gates opening once we hit our spike is still playing a role here. So potassium gates open to repolarize the cell. And remember, this is still voltage dependent. We will also close any sodium gates that we can, not leak channels, but sodium gates and calcium gates. The problem with the calcium gates is they close slowly. And so now we're going to draw what that looks like. So here's our baseline for our resting membrane potential. And we'll just say minus 70 millivolts. And now because sodium is leaking in much more than potassium is leaking in, we get this kind of depolarization that occurs. And once we hit threshold, we'll get now sodium, but mostly calcium causing it to reach a spike. And then sodium will close, calcium closes slowly, potassium is opening. And so it's more of a dome or a crest that we actually see, and we come back down to our resting membrane potential. Sodium's leaky, and then sodium, but mostly calcium, and then we get our spike, and it comes back down. To me, this almost looks like an action potential that's been really stretched out. You guys kind of see that also a little bit? So a super stretched out action potential. So again, sodium leak, calcium mostly. Now we hit our, I keep making the spike taller, sorry about that people, but we hit our spike. Calcium is closing slowly, potassium has opened up, but because calcium is closing slowly, that means that we still have not a rapid repolarization because calcium is still coming in a little bit because it's closing slowly. So that's what those spikes look like. Those are the nodal cells or the pacemaker cell spikes. So let's take a look at what we have here. We have 1 and 2 there. And this was our threshold. And then we actually have B here. So threshold is reached. So this is B. And then we reach our action potential peak, so to speak. And then this is C, where potassium gates are opening, sodium gates close, and calcium gates are slowly closing. RMP is resting membrane potential, which was a 70 millivolts. That's different. If you take a look at that, that's different than what we drew previously for a heart muscle cell's action potential. So pacer cells have a different looking spike or action potential than heart muscle cells do. Now let's take a look at those pacer cells in a little bit more detail. Conduction system parts. SA node, AV node, AV bundle, right and left bundle branches, and Purkinje fibers. Those are all conduction system parts, so they're like the nervous system of the heart, the intrinsic nervous system of the heart. The SA node is located in the right atrial wall just below the superior vena cava opening. It is not visible to the eye. It is something that you can only find on a histology slide. You can't feel it, you can't see it, it's within that muscle wall. And remember, the atrial muscle wall is actually quite thin. So here's our SA node in our picture, right in this area, and it's got all of its little wiring guys going all through the atria, both the right atria and the left atria. Remember, they're very close together. They're easier to find how close together they are on the posterior aspect of the heart. But that conduction wave is going to go throughout the atria, and it is going to only affect then the next part of the system, which is the AV node. The AV node is also in the right atrium, and it is just above the tricuspid valve in the interatrial septum. So here we're seeing our AV node. So the depolarization wave initiated by the SA node is going to travel to the AV node. And what's interesting about this, the reason it travels is because of gap junctions, right? So gap junctions are going to help this travel from cell to cell because that's all part of heart muscle cells. They all have gap junctions, and so do the nodal cells. They also have gap junctions with the next one down the line. So we're getting a depolarization wave and a repolarization wave that's going to be spreading throughout the atria. Ordinarily, we would think then it would spread into the ventricles. Well, what's really interesting is the atria only talk to atrial cells, and they do not talk to ventricular cells. So there's like this insulated gap between the atria and the ventricles where they do not talk, even though they have gap junctions in the atria and gap junctions in the ventricular cells. There are not gap junctions between the atrial and ventricular cells themselves in that area where the atria, so to speak, sit on top of the ventricles. The only way we can convey that we want the ventricles to experience the action potential, and therefore action potentials always bring around about contractions, is if that goes to the AV node. Because the AV node is the second place this is meant to travel. And from the AV node, it will then travel down the AV bundle into the interventricular septum. The AV bundle is also called the bundle of His. That's what most people actually are familiar with. And it starts in the interatrial septum and then goes into the interventricular septum until it splits into bundle branches. So we have left and right bundle branches. The left bundle branch is going to actually work on the left side of the heart, and the right bundle branch is going to work on the right side of the heart. It's going to carry this conduction wave down the interventricular septum to the apex of those ventricles and then up the outer walls of those ventricles. When it gets down to the bundle branches, it's going to innervate and cause action potentials of heart muscle cells in the interventricular septum, apex, and then finally the outer walls. In that sequence, are you guys following me with that? Because the bundle branches have connections to a next group of conduction system cells called Purkinje fibers. And the Purkinje fibers are actually the ones that are really responsible for making connection with the heart muscle cells of the ventricles. When the Purkinje fibers fire, then the heart muscle cells will contract. So this is an important conduction system of the heart. And any defect in any of these areas will cause problems with your heartbeat and therefore with ejection of blood. Let's add some notes to this now. The SA node in the right atrium, it will spontaneously depolarizes at a rate of 100 beats per minute. The SA node is called the pacemaker of the heart. Whenever we have a heart rhythm that is governed or directed by the SA node, it's called sinus rhythm. So the SA node has that 100 beats a minute spontaneous depolarization rate. And what we were just talking about up here is what I'm referencing to. Now, this 100 beats a minute is going to be sent to the AV node. And what's important about the AV node, it actually delays transmission of the impulse by 0.1 second. This allows for the atria to completely contract and dump what blood they have in them into the ventricles. If for some reason the SA node gets damaged, the AV node can take over the heart rate. And the AV node has a spontaneous depolarization rate of approximately 50 beats a minute. I'm going to put plus minus. In the books it says 40 to 60, so I just kind of took right in the middle of that, 50 beats a minute. Sometimes a little slower, sometimes a little faster. So if you run across somebody that's not an athlete and they have a heart rate of 50 beats a minute, you already know something. You know, the SA node is not working. So the heart is, it really is, it's born to beat. It's born to be a pump. And so the SA node is the dictator of the system. And if somebody takes out the dictator, there's a vice president, you know, so to speak, in the system. And so that person will then dictate the rate of the heartbeat. However, that person's or that node has a different spontaneous depolarization rate than the SA node. But if the SA node is in charge, the AV node will do what the SA node tells it, because it's spontaneously causing it to feel depolarizations at 100 beats a minute. It's just that the AV node says, okay, I'll send that on, just a second. And so every time the SA node beats, the AV node will beat, but it will beat or depolarize at a slight delay. So the atria, because remember, the SA node sent the depolarization wave through the atria, correct? And why do we depolarize muscle? To make it contract. So we're depolarizing that muscle area, and we want it to contract, and if it's going to contract, we don't want the ventricles contracting at the same time, correct? So we have that depolarization wave go through the atria. There's a slight pause before we send it on into the ventricles. But the atria and the ventricles do not actually talk to each other than through this very specific route, even though we've talked about their gap junctions. Now let's take a look at the AV bundle, also referred to as the bundle of His, which is the electrical extension from the AV node. And what we know about that is that the AV bundle is now going to take the information from the atria into the ventricles. No gap junctions between cells of atria and ventricles. So atria talk to atrial cells, and ventricular cells will talk to ventricular cells. What's interesting about the AV bundle, it too can spontaneously depolarize, because it's a backup system for if the AV node gets taken out. And its spontaneous depolarization rate is 30 beats a minute. So if you find somebody that's 80 years old with a heart rate of 30 beats a minute, you know two things have happened. SA node's not working, and AV node's not working. But the bundle of His is working, or the bundle branches are working, or even the Purkinje fibers are working, because they also have a spontaneous depolarization rate of 30 beats a minute. And the Purkinje fibers are the ones that make contact with the heart muscle cells. Yes?
Just a quick question. So once they're gone, they can't reheal, so that's when you get the pacemaker for days off, correct?
Correct. So the question was, if your SA node's gone and you're symptomatic, which means that you're trying to fall down a lot, you know, your heart rate is not enough to give your brain enough circulation and therefore oxygenation so that you can function properly, or you're having angina or other physical inability to perform, then because the SA node's not functioning, a pacemaker will actually be placed inside. And the pacemaker will be set, some of them are just stable rate, but it's going to be set at a higher rate than what the individual had that caused them symptoms. And if they're an athlete, they're going to have a pacemaker that's actually going to adjust its heart rate according to the activity level of the individual. But athletes typically don't get this problem, correct? It's the older people that get this problem. Bundle branches, let's just add a little note here. We have right and left. They are in the interventricular septum. And head to the apex of the heart. Once you get to the apex, we have all the wiring going to the outer aspect or the perimeter of the heart. So this is another thing for you actually to realize. When the ventricles contract, remember I told you the apex heads up towards the valves? Can you not see why that actually happens? Because we're starting our depolarization in the interventricular septum, correct? And it goes to the apex before it goes to the outer walls of the heart. And so that's why the heart has a very interesting contractile pattern. It has a twisty-turny, shortening pattern to it whenever it actually contracts and therefore ejects blood. Let's see, what else do we want to add to this? With the Purkinje fibers, also they send out connections to the papillary muscles. So we can say Purkinje innervate also our papillary muscles. Because remember, we want the papillary muscles to also shorten as the ventricle apex is coming up so that we can put appropriate tension on the chordae tendineae so we don't have those leaflets flapping into the atria. So we have to make sure everybody involved in this system gets proper information about what's happening there. You guys have any questions about how the heart is wired, so to speak? So a SA node, 100 beats a minute, and it is the one that's in charge because it's pounding on the conduction system the fastest, and so the rest will follow along. Because one of you can say, well, why not a heartbeat of 50 beats a minute? Well, the AV node responds to the SA node. You guys have to understand, as long as everybody's functioning properly, you respond to who's ever talking to you or giving you instructions first. Now, if the SA node is working properly, but the AV node is not, then you know what's going to happen to the heartbeat, correct? It's going to decrease, and it's going to be, if the AV node isn't working, then it's going to be 30 beats a minute. That's very unusual. The AV node doesn't get taken out before the SA node. It's typically the SA node that gets taken out. And actually, in your pig hearts, one of the little teeny tiny branches off of your right coronary artery goes to the AV node. So the right coronary artery has a little teeny little branch before it even gets into the sulcus, and actually it feeds the AV node. And so there actually is a good blood supply to that because it's that important. Now, whose heart beats on a regular basis at 100 beats a minute all the time? Nobody's. So there's an extrinsic control of the intrinsic system. Okay? As I said, the heart is meant to beat without anybody else telling it what to do. That's my analogy with ripping it out of somebody's chest. And that's another reason why you can take somebody else's heart and put it into somebody else, because it's already hardwired to actually beat at the rate that they need to survive. The extrinsic conduction system, or the extrinsic impact on the intrinsic aspect of the heart, is what we're going to talk about next. And we have the cardio accelerator center in the medulla oblongata of the brain. It will increase, as the name says, it will increase the heart rate. And it is related to the sympathetic nervous system. The cardioinhibitory center, just as the name sounds, it will decrease our heart rate. And it is part of the parasympathetic nervous system. Do you guys remember what cranial nerve goes out of the skull and wanders around and feeds all the body parasympathetic innervation? It's the vagus nerve. Absolutely. So cranial nerve, 10. So the vagus nerve is the cardioinhibitory center. We'll talk about how it actually slows down the heart rate in just a little bit. Let's take a look at the ECG because you guys are going to be doing that next week in lab. ECG is for electrocardiogram, and it is just truly a graphical recording of electrical activity of the heart. So if it's the graphical recording of the electrical activity of the heart, what does it tell you about the heart? It tells you what the heart is doing electrically, yes? Does it tell you what the heart valves are doing? No. So it's always telling you about what the heart is doing electrically, and if the heart muscle is responding, then what you see electrically will tell you also what the muscle is doing, correct? There is actually a condition where the electrical activity disassociates from the muscular activity, and so even though you see electrical activity, the muscle's not responding, and that's a very deadly situation, correct? Now, the other thing about an ECG is that it will tell you if there is a problem area in the electrical conduction. Because why do people get ECGs? Why do, when they go to the hospital, it says, well, we're going to get an ECG on you. Why? There's something wrong with the heart. And most commonly, the most common reason that they're worried about something wrong with the heart is a heart attack. So a heart attack means that heart muscle cells are dying, correct? And if heart muscle cells are dying, do you think there will be an abnormality in the electrical transmission of the impulse? So that's why an ECG is useful for heart damage, heart muscle damage. It can't tell you about what the valves are doing or anything at all like that, but it can tell you if the heart muscle is intact and if the electrical conduction system is intact. And if there's a deviation from that, then you can actually tell a lot about what's going on with the heart. So just the electrical activity of the heart, and it is measured at the body surface. It's not we aren't putting any sort of electrodes on the heart. We're actually putting electrodes on the cage around the heart, correct? And so what's important about that is that, do you want somebody being very active while you're doing an ECG? No, and the reason for that is the increased physical activity is actually related to electrical activity of skeletal muscle, correct? And so that will cause interference with the reading. And so the ECG also has a system that tries to minimize or take out any sort of skeletal muscle activity associated with it. And so it does a pretty good job of actually measuring what's going on at the heart. So our notes, we should add detects conduction, system damage, and or heart muscle damage. There are upward deflections of the ECG, and this is all related to vectors, and that's what you'll be learning about in lab next week. It's vector related. And so you have to understand the electrical activity of the heart, because the heart hangs kind of from right to left, correct? Across your sternum, underneath it. So from right to left, and the electrical activity goes from superior to inferior, correct? And so all of these upward deflections that you see indicate that the electrical activity is going from superior to inferior in the way it's supposed to actually go. So we have depolarization first of the atria, correct? That's our P wave. So atrial depolarization, that upward deflection that you see, is the P wave. The QRS complex is very narrow compared to the P wave. That is ventricular depolarization. You see it has a little bit of a downward, teeny tiny little downward spike, and sometimes you'll never see it at all on an ECG, but it has a definitely large, narrow upward spike that will come back down beyond baseline for that little little spike and then come back up. So the QRS complex is tall and narrow, and that is ventricular depolarization. Well, the ventricles are really large structures, so that makes sense that it's so tall. What's fascinating is that it tells you that the depolarization rate through the ventricles is actually faster than it is through the atria. So when we get ventricular depolarization, it goes actually at a faster rate than what we see with the atria. Then the T wave over here is ventricular repolarization. Well, remember, the ventricles are depolarizing at the interventricular septum apex and then the outer aspect of the ventricles. And wouldn't the repolarization also go in that similar pattern first? And so that's what we see. When we see these upward deflections, it tells you everything is traveling the direction it's supposed to travel with the conduction system of the heart. Now, the only thing that we don't have listed here, because we have atrial depolarization, ventricular depolarization, and ventricular repolarization, we don't see anything about atrial repolarization here, correct? When would atrial repolarization, when should it be happening? The same time the ventricles are depolarizing, correct? And so it's hidden in that QRS. So that QRS actually is covering up our atrial repolarization. Those are the main highlights of a simple ECG recording of the heart itself, the heart conduction system.
ECG or EKG? I mean, why do they have this?
Electrocardiogram is the ECG, and the EKG is because it was Germans that first actually invented the electrocardiogram.
Oh, so they're interchangeable.
Yes. And Germans spit a lot in the electrocardiogram. So, and it is actually with a K for Germans. So that's where the K came from originally. So the simple story of things. Now we're going to go into what's called the cardiac cycle, and that is the events of one heartbeat. Diastole is synonymous with relaxation of heart muscle. Systole is synonymous with contraction of heart muscle. Which one of these two terms should we also associate with depolarization, and then the other one with repolarization? Systole is depolarization, and diastole should be associated with repolarization. Good. Blood flow in the cardiovascular system is always going to be from high pressure to low pressure. And this is similar to what we did with diffusion and osmosis, high concentration to low concentration. So blood will flow from a high pressure area down a low pressure area. That's what it wants to do. Now, when we actually have a heartbeat, we are ejecting blood into the vascular tree, correct? Let's take a look at what happens sequentially in order for blood to be ejected into the vascular system. Besides the terminology, now our next topic here is atrial contraction and ventricular filling. This actually starts in mid to late diastole. So ventricular filling, that means the atria is dumping its blood into the ventricles, right? And so atria contract and finish the ventricular filling in mid to late diastole. And this is diastole of the ventricles. I hope you guys understand, because the largest part of the heart are our ventricles. And so whenever we talk about, when I say diastole or systole, And I don't specify whether we're talking about atria or ventricles. I am talking about ventricles because that is the bulk of the heart. If I want to talk about atrial systole and diastole, I will definitely say atrial systole and diastole. Atria are contracting, which is a systolic event for them. Ventricles are filling, which is a diastolic event for them. And, of course, the ventricles are relaxed because they're in diastole. Atria will contract because they are undergoing systole. And when the ventricles are relaxed, what is the internal pressure of the ventricles going to be like in comparison to when they are contracting? Pressure is low. Diastole and internal pressure, low. When the atria contract and therefore are in systole, what do you know about their internal pressure compared to when they're in diastole? High. So internal pressure is high. And therefore, what do you also know about blood flow? It goes from high to low, correct? So here again, we're also reinforcing atrial pressure is high, ventricular pressure is low. Blood is going to flow from the atria into the ventricles, and therefore, what do we know about the AV valves? They have to be open for this to actually occur. Open. Therefore, blood will flow from high to low pressure. End diastolic volume. What am I talking about here? Atrial or ventricular? This is ventricular end diastolic volume, so that means at the end of the relaxation of the ventricles, we have been able to put into the ventricles 130 milliliters of blood. That's not very much blood, is it? 130 milliliters is, how many milliliters to an ounce? Isn't it 30? 30 cc's? That's a little over 4 ounces, right? So a little over 4 ounces of blood is inside your right and left ventricle, correct? Because we already talked about they both pump the same volume of blood. Otherwise, we'll end up with some problems, backup problems. So now we're going into ventricular systole. Well, when the QRS is happening, that's a ventricular systolic event, correct? Ventricular systole begins as the atria go into diastole. Yep, that makes sense because the atria are now going to relax and the ventricles are going to contract. Our intraventricular, the pressure inside the ventricle, will actually rise very rapidly when this actually occurs. And what do we know will happen to the AV valves? They are going to close. So AV valves close. And the ventricles will go through a phase called isovolumetric contraction. Isovolumetric means the volume is going to stay the same. Now, that makes sense that the AV valves would be closed, but what do we know then about our semilunars if we're going through isovolumetric contraction? They're closed too. So AV and semilunars are both closed. So all valves are closed at this stage. That's why it's called isovolumetric contraction. And the pressure will continue to rise until the pressure in the ventricle is greater than the pressure in our aorta or pulmonary trunk. trunk, if we're on the right side, or our aorta, if we're on the left side. Why do we know that there's actually pressure in our pulmonary trunk or our aorta? It's a closed circuit system, so that means there's fluid throughout the system. You guys follow me? Everywhere you go, there's blood. Everywhere. And so even though our AV valves are closed, and let's stick with the left side because that's what most people relate to, even though our semilunars are closed in the aorta, there's still blood that's left over. Because remember we talked about how the blood rises and then falls back on those valves? So there's that back pressure that exists in all of the plumbing of this system. And so the ventricles are going to contract, and the pressure on the fluid inside the ventricle will increase because of the contraction until it squirts it out into our aorta. And it can only do that when its pressure is higher than the aorta, and it will force the semilunars along the wall and open up the semilunars at that stage. But we have that time of isovolumetric contraction that actually really does happen before the semilunars actually open up. So we get ventricular ejection because then our blood will move into the arteries, pulmonary trunk or aorta, depending upon where you are, because P in ventricles, again, is greater than P in these arteries that we were talking about. So we know semilunars open up. What do we know about the AV valves? What about the AV valves? They remain closed. And they're closed because this valvular system is designed to keep that blood from backflowing into the atria. So that's what the AV valves are going to do. They're going to remain closed. At the end of ejection, we have a term here, end systolic volume. Systole is contraction and therefore ejection. The end systolic volume is actually 60 mLs. We have 2 ounces of blood still left in our ventricles, even after they eject a whole bunch of blood out. So there's always a little bit of blood left over. It's hard to be 100% effective in actually ejecting all the blood that's within you out into the system. So there's always a little bit left over. And this is the average, about 60 mLs or cc's are left over. That's the end systolic volume. What was the end diastolic volume? 130. So end diastolic volume number is greater than the end systolic volume. And that should be that way, correct? You wouldn't want to have a larger blood volume in your ventricles at the end of systole, would you? You guys thought it was going to be 0, right? Well, it's not. It's actually 60, but it's definitely going to be less than end diastolic volume, which is the nice, relaxed, full ventricles. Now we're going to go into, because we've finished our contraction, systole, we're going to go into diastole. And you know that the intraventricular pressure will absolutely drop. And what do we know about our semilunars? Semilunars snap shut. Absolutely. Because blood wants to flow back into a lower pressure system. And we put a whole bunch of blood into the arteries, which means we've increased the pressure in the arteries, correct? And by ejecting all this blood and going into diastole, haven't we decreased the pressure in our ventricle? So our blood wants to actually flow back into the ventricle because it actually is now lower pressure than the artery that's associated with that ventricle. So semilunar snap shut because blood wants to flow from high pressure to low. And our high pressure right now is in the artery, and the low pressure now is in the ventricle in comparison. So semilunar snapshot at the beginning of ventricular diastole, and then the ventricles go through isovolumetric relaxation. Again, this means all valves are closed. So this is semilunars and atrioventricular valves. This time is very short. Because the ventricular pressure is rapidly becoming less than the atrial pressure. And when ventricular pressure becomes less than atrial pressure, then the atrial blood will flow from the atria into the ventricles, and the AV valves will open in order for that to actually happen. So AV valves open, and blood flows from our atria into our ventricles. I'll just say V. And what's important about this is that this is passive. And the reason I say passive is this actually happens before the atria contract. So the atria are not even contracting in order for the blood that they currently have to actually flow into the ventricles. It is truly a pressure differential. Ventricular pressure drops, atrial pressure is higher, AV valves open, and blood literally falls into the ventricles. So it's a very passive process. And that's the beginning of the diastole for the ventricles. Remember, in mid to late diastole, the atria will contract, and a little bit of, and where's the contractile area of the atria actually? It's in the auricles. And so a little bit of blood that was in those auricles gets pushed into the ventricles. So it's not a large volume of blood that atrial contraction actually delivers to our ventricles. Ventricular filling is passive for the most part. That is why people who have atrial fibrillation do not necessarily get any treatment other than blood thinners, right? So atrial fibrillation is where the atria are not contracting properly. They're just wiggling like a little bag of worms. And it's not a big deal for cardiac output because the bulk of ventricular filling is actually a passive process. The little bit of blood that atria literally contract into the ventricles is actually quite small. So atrial fibrillation only needs to be treated for the possibility of clot formation. And one of the things that I want to talk to you about clots, blood clots, is blood is designed to move. And when blood sits in an area for too long, guess what it ends up doing? Forming actual clots. So blood should be moving, and that's why when people travel in airplanes and get those blood clots in their legs, the reason they got the blood clots in their legs is they had too much pressure on the backs of their legs, causing a decrease and sludging or slowing down of venous return, and those clotting factors started to overcome the anti-clotting factors in the bloodstream. So when the little auricles of your atria are not contracting anymore, guess what the blood does? It stagnates in those. And that's why people are treated with blood thinners, because it's the atria that can actually generate the clots. That's not a good sign because the atrial clots will go into the ventricles, which will then go out to the rest of the system, whether it's lungs or systemic for your body. So atrial fibrillation is not a blood delivery problem, it's a clot delivery problem. Quiescent period, quiet time between cycles. So now let's talk about the time in between cycles, because this is another challenging thing about the heart. Heart sounds. 2 heart sounds. Try not to read the notes just because I want you to think about this first. The heart sounds that you hear are typically referred to as lub-dub, right? Lub-dub. And they're due to valve closures. We literally hear the heart valves snapping shut. Just like if your kid's mad at you, you hear the door slam shut. Yep, they're pissed off. Okay, you already know it. So you hear the closure of the valves, not the opening of the valves. Okay, so now lub-dub. We know that now it's heart valve closure. It's either going to, one of them is going to be AV valves, and the other is going to be semilunar valves. So which one closes first? Semilunars or AVs? AVs. So LUB is AV valve closure and DUP is semilunar valve closure. So let's take a look and see if we agree with that in the notes. 2 sounds can be heard, auscultated in normal individuals. First one is due to AV valve closure, and second one is due to semilunar valve closure. This is what I really like you guys to do. Once you learn this, it's also easy to memorize, but if you understand the cardiac cycle, then you can easily predict what the LUB and the DUP, or the first heart sound and the second heart sound, is actually due to. So then my question to you next is about which lasts longer, systole or diastole? Systole or diastole? Think about this. Now stop, think. Which lasts longer, systole or diastole? Diastole. Because remember, filling occurs during diastole, and which one is going to take a little bit more time? To eject or to fill? Because ejection is actually a physical process, and I just told you that filling was a passive process, didn't I? So ventricular filling is predominantly passive, which will therefore take more time, and ejection is actually pretty rapid. When you squeeze something, you're going to squirt it right on out. So LUB-DUP, the time between the first heart sound and the second heart sound is at diastole or systole? It's systole, isn't it? And so then DUP-LUB is actually diastole, right? LUB-DUP is time that systole occurs, and DUP-LUP is the time that it takes for diastole to occur. So that tells you first heart sound is tricuspid or bicuspid closure. Second heart sound is aortic and pulmonic valve closures. Cardiac output, and that's abbreviated CO, like carbon monoxide. Cardiac output, the amount of blood pumped by a ventricle in 1 minute. Well, they're going to pump the same amount, correct? So that's why we say a ventricle in 1 minute. So we have some other terms here. Stroke volume, the amount of blood pumped by one ventricle in 1 beat. And we already figured that out as 70 mLs or cc's, right? Stroke volume for an average, 70 mLs. That's an average. Stroke volume also will have a formula for it. It's EDV minus ESV. So stroke volume equals EDV minus ESV. The E stands for end, and the V stands for volume. So what does the D and the S stand for? Diastole and systole. And didn't we say End diastolic volume is when the ventricles are the most full, and end systolic volumes are when the ventricles are the least full, but still have fluid in them. And so we said our end diastolic volume was 130. We said our end systolic volume was 60. And therefore we get 70 mLs or cc's, whichever one you prefer. Which is what our little cartoon shows right below us, but you know, it's the impression is made better in your brains if you actually write it out. So now cardiac output, that CO, equals stroke volume times heart rate. So CO equals SV times HR. And so CO equals stroke volume, well, that's going to be 70 mLs times heart rate for an average person is about 75 beats a minute, we'll say. And that will end up giving us, when we do the math, 5.25 liters. What's the average volume of blood in a man? It's about 5 liters, and about 4 for women, yeah? So in a minute, your heart will actually pump you dry, correct? If there's a big hole in your vascular tree, right? So that's why somebody losing their limb, you want to apply a tourniquet as fast as you can, correct? Because you don't have a lot of time to keep that blood loss from actually occurring, especially the larger the blood vessel. Ventricular balance, this is to remind you that an equal amount of blood is pumped by either ventricle. If the left side, which is pumping blood to the lungs, pumped less blood to the lungs than, if the right side, thank you, I wanted to go to the lungs. If the right side was pumping less blood to the lungs than the left side, it's pumping out more blood to the body, where would we end up experiencing fluid leaking out of the capillaries? In the legs. And if the right side is pumping more than the left side, what that means is the left side is where the backing up is actually going to occur, and that will actually cause fluid to actually come out in your lungs and cause pulmonary edema. Or heart, sometimes what they typically call is heart failure when you start to hear blood accumulating in the lungs. But heart failure is also seen in the legs, correct? Heart failure is pump failure. The worst case is when both pumps fail. So, and that's indeed congestive heart failure, typically have rales or crackles in their lungs as well as edema in their legs. So that's a double pump, or both pumps are failing on the individual. You're actually moving along really well. Regulation of the heart rate. We just touched on it last time, a little bit ago. Autonomic nervous system, ANS, is the extrinsic control to our heart. Sympathetic, fight, flight. Parasympathetic, rest, digest. The neurotransmitter of the sympathetic nervous system onto the SA node. So what this is, this extrinsic control is at the SA node. So we actually have sympathetic fibers running to the SA node and parasympathetic fibers running to the SA node. So we have both fibers going to the SA node, telling the SA node, fight, flight, rest, digest. So let's take a look at the neurotransmitters the sympathetic nervous system is releasing at the SA node. It is releasing predominantly norepinephrine. Epinephrine can also do this, but the sympathetic nervous system is releasing at the SA node norepinephrine. This actually causes more rapid depolarizations of the SA node. This results in increased heart rate, correct? More rapid depolarizations, that means fire, 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 fire. Increased heart rate. Now, based upon our previous drawings here, more rapid depolarizations are going to affect this, correct? So will it become less steep or more steep? More steep, which means more leaky to sodium. You guys follow that? So this is causing an increased sodium leakage issue. And this causes an increase in the slope, and therefore we get to threshold faster. The parasympathetic nervous system is going to want to slow us down. So the sympathetic nervous system, indeed, will increase the heart rate. The parasympathetic nervous system is designed to slow us down to rest-digest mode. And the neurotransmitter released on the end organs of the parasympathetic nervous system is acetylcholine. And what's interesting about acetylcholine at the SA node, it opens potassium gates. Well, when you open the potassium gates of the SA node, what does that mean about resting membrane potential? Does that go up or does it go down, more negative? Down, more negative. So that's causing a hyperpolarization, correct? Which means it's harder to depolarize the SA node. So therefore it slows down the depolarization of the SA node and decreases heart rate.
So if your SA node is now 0.8, then do these all affect the 18 node now?
See, that's why the SA node is so important. The SA node is the dictator of the system, knows what the base heart rate should be, and will listen to the sympathetic and the parasympathetic nervous system and adjust the heart rate accordingly. So most of us are at that 75 beats a minute, which means that we're getting parasympathetic stimulus to our SA node, and it's slowing down its depolarization rate, and therefore everybody else is slowing down because he's like the conductor. And whatever the conductor says the rate is going to be for everybody else, that's what the rate is, as long as everybody else is healthy. Yes?
In sympathetic dominance, would stroke volume decrease?
In sympathetic, that's why being in sympathetic dominance for a long period of time is not necessarily great for you. However, one of the things about adrenaline, which is norepinephrine and epinephrine, it improves the contractility of the heart.
Okay.
So yes and no. You know, yes if you had a weak heart, and no if you have a normal heart because your contractility, which means your ejection of your blood, is enhanced, correct? Because that's what improved contractility of the heart is actually all about. That's why athletes actually, guess what their end systolic volume is? Is it the same as everybody else's? No, it's lower because they have so much more efficient hearts, better contractility to their hearts. Yes?
The passive filling of the ventricle, is that what puts a cap on our effective heart rate?
For somebody who's not well trained, so the question is, does the passive filling of the heart cause the cap of what our effective heart rate should be? And yes, for an individual that is not well athletically trained or hardened, so to speak. But if you continue to train, you will continue to actually enhance your contractility of the heart and therefore improve the ejection or emptying. And also, you have to realize the bigger the heart muscle, how flexible are bodybuilders, by the way? Not. So there's also a downside to athletes training heavily because they can get very thick ventricular walls, which means how well will they distend when you're trying to fill them. So it inhibits their distensibility the thicker they are. And that's why enlarged heart muscle hearts, hypertrophic cardiomyopathy. Can you figure out what that means, hypertrophic? Yeah, these hearts that have super thick walls, that's why that is bad for them, because they don't actually fill as well because they've lost the pliability for getting a good volume in them. So there's a lot of different factors that affect the filling of the heart. Why don't we go ahead and stop here, because we'll start next week on, we'll finish this up and then start on blood vessels, and we'll be right on track for our upcoming exam.